Another finding which is described are these patchy A-space consolidations. Okay, so these are described in the alveolar sort of alveolar description of sarcoidosis. And as we said previously, it characteristically involves the upper and mid zones. These can mimic consolidation or any lung infection and also organizing pneumonia. So these are your patchy areas of consolidation. But you can note that even along with these patchy areas of consolidation, there are small nodules. There are subpleural nodularity there, here. Okay, there is some interlobular septal thickening probably there, and some peribronchovascular septal thickening in this region. It looks a bit thickened than normal, okay, along with patchy areas of consolidation. And this is frank consolidation itself involving the upper zones bilaterally. Again, a case of sarcoidosis. Or the usual pattern, okay, you can't say just based on this one image that this is sarcoidosis. You have to give differentials also. There have been descriptions of almost mass-like lesions. So on the chest radiograph for the same patient, okay, where the CT image has been taken from, you can see multiple bilateral lung masses. Now, you can't call this sarcoidosis straight off. Okay, you would probably not be wrong if you say this could even be metastasis. But they just mentioned that in some of the sarcoidosis masses like these, you can get air bronchograms, okay, which could be part of some infection. But this has been described in sarcoidosis also. Miliary pattern. So although we say this, I'm sure it's in your differentials for miliary pattern sarcoidosis. It's a rare finding though, okay, but it has been described. And this is how this is a case of sarcoidosis. So micronodules giving almost a hematogenous spread because it's diffusely involving the entire lung there. And you won't be mistaken if you call this initially as tuberculosis or even histoplasmosis before finally giving a DD of sarcoid. Lymphangitis carcinomatosis like findings have been described in sarcoid, again characteristically involving the upper and mid zones. And more than the nodules and the reticular pattern, there's significant involvement of the interlobular septa, or there is thickening of the septa. An example here, so you can see nodules going on there, and along with the nodules at places you get these thickening of the septa, and that gives you a reticular pattern almost. Okay, that is thickening of the septa there. So along with the nodules, and this can be seen in lymphangitis carcinomatosis. Pleural involvement, not very common. So what can you see in sarcoidosis? You can see along with thickening of the pleura, you can see effusions. And sometimes you can even see pneumothorax. But pneumothorax is much more common in the late stage, which is the bullous sarcoidosis, or fibrotic involvement of the lungs with bulla which rupture, and that can give rise to pneumothorax. This is an example of sarcoid, pleural involvement in sarcoid, and you can see the pleural thickening along with the effusion. Now, final stage for sarcoidosis would be lung fibrosis. One of the studies which it has taken into, which has looked into CT findings in sarcoid, I've seen that it's basically these ground glass opacities and consolidations which were seen initially, which finally tend to evolve into honeycombing, which is a classical sign of lung fibrosis. And honeycombing, once we take it as irreversible disease. And I'll tell you what would be reversible versus irreversible findings on CT in sarcoidosis later. And conglomeration of masses, okay, we said these areas of consolidations which can appear mass-like, finally, they coalesce together, and that causes bronchial distortions and finally leads to fibrosis. That's a disease progression in sarcoidosis which leads to lung fibrosis. This one thing to differentiate fibrosis in sarcoidosis from your idiopathic pulmonary fibrosis, okay, which has the UIP pattern. Now, UIP pattern is basically involvement of the basal lung, basal peripheral lung with honeycombing. In sarcoidosis, however, as we said, it's a disease which involves the upper lungs. Okay, so here it's the honeycombing is seen more in the perihilar locations and also in the upper peripheral lung. I'll show you examples. This is a case of end-stage disease in sarcoidosis, where you can see these cystic changes here. And we haven't got multiple sections, but this is the honeycombing at the periphery, but involving the upper zones and also perihilar in location. And there's also distortion of the bronchi here, okay, because it's involved the airways at this stage. In the midcell window, you can actually see the nodes, okay, which would tell you, which would point you towards sarcoidosis. Of course, the location also, we've said upper zone involvement, and these nodes, okay, will tell you that good chance this is sarcoidosis fibrosis. So a nice chart which tells you, when you look at individual findings, what's the diagnostic confidence of sarcoidosis? So large bilateral hilar adenopathy is a classical description. So even just bilateral hilar adenopathy, when you see it in isolation, the diagnostic confidence for sarcoid is very high. Okay, so the third one is the diagnostic confidence for sarcoidosis. That's the third column there. When you get unilateral adenopathy, just isolated, you can't be sure. But when you get that along with perilymphatic micronodules, yeah, then we would be thinking more towards sarcoid. Similarly, when you get some of the mediastinal nodes, for example, internal mammary or pericardinal, or what they mean by pericardinal are your paracardiac nodes. Paracardiac nodes are not common. So isolated, these nodes are very rare in sarcoid. So just remember, internal mammary nodes or paracardiac nodes are much more common in lymphoma. Coming to your micronodules, perilymphatic nodules, when you see it along with the cluster sign, she said the sarcoid cluster sign, has a high incidence for sarcoid. When it's added with bilateral adenopathy, you can be almost sure that's sarcoid to be given as the first differential. Now, when you get nodular masses or areas of consolidation, okay, just these things by themselves are not very characteristic. But when you have these consolidations or nodules along with the sarcoid galaxy, there's a high chance it is sarcoid there. Cavitations by themselves are not characteristic of sarcoid. If you get a cavitary nodule, do not say sarcoid straight away. Maybe as your fifth or sixth differential, fine, but don't give it as sarcoid straight away. Okay, but when you have cavitations along with bilateral lymph nodes, yeah, then sarcoid can be somewhere in the picture. Or with your sarcoid galaxy sign, which we said earlier. Ground glass opacification, very non-specific. I don't think anybody will say with ground glass opacification that is sarcoid. Okay, so it's, I think, self-explanatory. But of course, when you get perilymphatic nodules, micronodules, yeah, think of sarcoid. And again, when they've said along with bilateral perihilar lymphadenopathy. And pulmonary fibrosis, again, just by itself to say sarcoid, not easy, or you shouldn't. But when you have pulmonary fibrosis associated with other things, yeah, then upper zone distribution, think of sarcoid. Okay, so just to summarize, the important things are your symmetrical bilateral hilar adenopathy, perilymphatic micronodules, and your sarcoid galaxy. These are your more classical representations of sarcoid on CT, okay, or even on a chest radiograph.